All right, well, welcome everyone, and thanks for joining. In terms of our agenda for today, I just wanted to go over, start with a bit of an introduction about CBRC, ACCH, around a bit of a land acknowledgement. We're going to do a little bit of a check-in around just HIV self-testing. We're going to talk about some Alberta data around HIV testing, and then get into the self-testing itself. At the end, there'll be a Q&A and some wrap-up. Please use the comments to ask questions. Ricky is going to, unless it's very pertinent to the specific slide that we're talking about, we're just going to answer all the questions at the end in the Q&A. Please just send it in as it comes through, but we may not answer it until the end. Yeah, and I'm really looking forward to talking with you about this all. Just really to start with a land acknowledgement here. I wanted to acknowledge that we're on the traditional territories in Alberta of many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. Many of the people attending this presentation come from Alberta and are currently living there. And, you know, thinking a little more broadly as well, too, about some of the presenters on here. So CBRC is a national organization, and our work spans across the unceded, ancestral, and traditional territories of First Nation peoples on land that is currently occupied and known as Canada. And we recognize and are grateful for living and working on these lands that have been cared for by Indigenous peoples since time immemorial. Myself and Ricky, we are situated on the traditional territories, the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the New Credit First Nation in what's currently known as Toronto. And really just spending a moment to think about what a land acknowledgement is. You know, thinking about the topic that we are discussing around HIV self-testing, when we look at the statistics on Indigenous people and the burden of disease in HIV, they are disproportionately affected. Approximately 10% of people living with HIV in Canada are Indigenous, whereas the population, they represent about 5% of the population. So when we think about all of the factors that lead to this, including anti-Indigenous racism, colonialism, and the social determinants of health, you know, it's very important for us to think about this work. And, you know, a land acknowledgement isn't just us saying that we're settlers on this land. And I realize that some of you, Celeste included, is not a settler on this land, but many of us are. And so I really just wanted to take a moment to reflect on that. A little bit about the Community-Based Research Center. So we promote the health of queer men through research and intervention development. We are inclusive of bisexual and queer men, both cis and trans, and two-spirit people. We are also starting to do a bit more work broader in the LGBTQ2+ sector, which please visit our website for some very exciting announcements around that. And really our core pillars are positioning us as a thought leader, the organization as a thought leader, and transforming ideas into action that make a difference in our community. So this presentation is an example of where we are hoping to share some things with community members and to help increase the capacity for organizations to be able to provide services to people. You know, recognizing that ACCH provides oversight more broadly beyond queer men, information around other people impacted by HIV. So really we're trying to balance those two just with the two different organizations. Celeste, did you want to say anything about ACCH briefly, or?
No, that's okay. I think most people here know about ACCH and the things that we do. Thank you. Okay,
well, thank you. So just to start off, we're going to do a little bit of a check-in. Ricky's just going to put this into the chat. There's a menti.com, and if you enter this number, then we're just going to do a brief activity, and then afterwards we'll come back and do a Zoom poll. So I'm going to stop sharing my screen for a moment and switch screens. And when you get to the point in Menti, just feel free to start entering information around what do you know about HIV rapid testing. And so this isn't necessarily around self-testing, this is just about rapid testing in general. And hopefully there will be a word cloud that shows up on here. Yay, it's working. I always love it when technology actually works. Maybe take 30 more seconds. As I see, about 8 people have put something in. All right, so seems like prevention is really this one aspect that seems to be the most salient concept around this, as well as community-based, effective. But I can see some other things around both inaccessibility and also low barrier. So it's quite interesting how maybe where we're each individually situated, how we might think about it from those different perspectives. And then, you know, really just thinking about like whether it's accessible or inaccessible too. So it's quite interesting to see that difference between those two aspects. Let me just see if I can move on to the next question. So thinking about the barriers that people mentioned, what barriers exist in implementing Hello, sorry about that. Can everyone hear me? This is the pleasures of working from home. Sorry, I think that the previous poll wasn't working, but I think we're just moving on, and that's fine. So thanks for filling out, Ricky, continuing along with it. So in terms of the this poll here, so is HIV self-testing an exciting addition to your work? It looks like everyone seems to agree, and there's quite a bit of interest in implementing or supporting HIV self-testing. So I think I'm really pleased to hear that, and I hope that the information that we're going to be sharing will help people feel more empowered to be able to do that, and that some of your organizations will participate in the work that we're doing. So just giving a little bit of background around the HIV epidemic in Alberta. As you can see here, so this is some data from Alberta Health Services, their July 7th, 2020 STBBI update. The 2019 data is preliminary. And as we can see here, while there was a little bit of a peak in 2016, 2017, particularly in Edmonton and North region, it's been fairly consistent in terms of the case rate, maybe a little bit of a reduction in some areas, but definitely not to the point where we are close enough to end the HIV epidemic by 2030, which is a UN AIDS goal. In terms of some of the specific data, this is again from AHS. This is exposure in women in Alberta by category. And as we can see here, for women, the main exposure category is immigration or out-of-country exposure, and has been increasing in terms of percentage. And the rest of the categories are all kind of in the same range, with really a bit of variation in between. Looking at cases among men, I'm sorry, the colors may be a little hard to tell, but the top blue line is men who have sex with men, or what CBRC refers to as GBT2Q. And then as well, there is the second line below that is the immigration / out-of-country exposure, with, again, the rest of the categories representing about 10%. So really, the main message here is, as we're all likely aware, that different portions of the population are differentially impacted by the HIV epidemic, and it's very important for us to consider programming that addresses those differences. Thinking about the current HIV testing landscape, there are a variety of access points into HIV testing. So primary healthcare providers, sexual health clinics, ASOs, in the sense of facilitating people to move into HIV testing, and things also as well too, like the places of last resort, like ER for HIV testing, and sometimes walk-ins as well. And the types of testing, so we have our blood draw, which is the standard way to diagnose HIV, which takes about 1 week for processing and to get back to the client. The rapid point of care test, which is about 1 minute once the blood is actually in the device. And then DBS, so this is dried blood spot, and this is something that is used more in rural and remote communities, and it can take longer than a week just because it does need to be processed by the lab. So thinking about the benefits and barriers to the current system, really, I think the main benefit that the system currently has, aside from the fact that it's so well developed, is that it's an opportunity to interact with healthcare providers, receive post-test counseling. Other STI testing can also be included, and other prevention services, whether this is PrEP or contraception, or talking about condoms or vaccination, or whatever that happens to be. So there are many benefits to the current system. When we think about what some of the barriers are, so we're limited by the choice, and this can vary drastically between the different regions. And we work within a system that has finite resources, so there are limited resources available to testing, which includes access to healthcare providers, and this really plays into wait times. And I think that's something that is a challenge across the Canadian healthcare system. And lastly, and I think this is also something that's particularly important for sexual health and HIV, is the HCP characteristics. So the level of knowledge that they have around not just HIV, but the factors that lead to people acquiring HIV, and also stigma associated with both sexual health and potential HIV acquisition as well. And then just moving on to the HIV Care Cascade. So again, this is part of the UN AIDS targets. And really, this is, when we're talking about this, is the 90-90-90 targets of 90% people who have HIV know that they're infected, 90% are linked to care, and then 90% are virally suppressed. And so I'd like to just spend a moment to think about what this looks like in terms of HIV self-testing. So really, it's a very complex web of how HIV self-testing and testing in general leads towards all these linkages. And you can see many of these arrows are bidirectional. I'll say this isn't a theoretical model. I'll actually say Celeste was very kind to put this slide together. It was her much better slide than the one I had created before. And so really HIV self-testing is a way to both link people to standard testing and also to link them to other different services. And I think it's also very important to recognize that, you know, once someone has a self-test, they can choose what they want to do with that information. If they have a reactive test and they choose not to follow up with their health care provider or can't access a healthcare provider for whatever reason, then we need to be thinking about how can we build either trust or capacity or whatever is missing into the system so that we are able to screen people through standard testing so that they can achieve those both for their own health and also for the health of the community. They're able to achieve, get on treatment and achieve viral suppression. So, introducing HIV self-testing. Many of you will probably recognize this as the currently available point of care test. The current test that is going to be shortly available for self-testing is very similar to the existing point of care test, and have quite a bit of more information around that. I did want to just kind of talk about the three different categories. So like I just said, there's the INSTI test, which is the current one that's available, manufactured by Biolytical. So all of the validation research in Canada is complete. It's under review by Health Canada, and we are hopeful that there will be an announcement about a license for this test to be available in the very near future.